Thank you, sir, for that long introduction. So here I'll be speaking to you a little bit about our experience with intraoperative STOCT in vitreomacular interface problems and how it has helped us. I have no financial disclosures. We've used this for a couple of cases during the time we had this instrument. Of course, we don't have any long-term studies as to whether it's going to help us further, but one thing I would say is that it's not an absolute necessity because a lot of us are still operating without the intraoperative OCT, but it's definitely a luxury. If you have it, you're able to see a lot of things during surgery, and it makes some surgeries a lot easier if you have it. So what happened over the last couple of decades is that OCT has basically revolutionized imaging of ocular structures and various disease conditions as well, and it has only recently found its way into the operating theatre. But early attempts at intraoperative OCT, the handheld ones, has already improved our understanding of surgical pathology and the role it may have in surgical decision making quite well. But there were always some problems associated with the handheld OCT in terms of it being a little cumbersome during surgery and also some sterility related issues. So hence it made sense to actually integrate the OCT along with our surgical microscope, and we used a device called as Optilumera 700 and the Rescan 700, both are from Zeiss. This is the first surgical microscope which actually has an integrated commercial OCT. So going on to some of the technical details, it is a spectral domain with a wavelength of 840 and a scanning speed of 27,000. The A-scan depth is 2 millimeters and an axial resolution of 5.5 microns. The surgeon can actually select the scan length, the angle and the location either by using the foot pedal control or through a video monitor display system that there is. You can have both live and a capture acquisition with this device. So how does it really help us in our surgical procedures is that even right from the beginning of surgery, one second, I think, yeah, so right from the beginning of the surgery you can image the anatomical configuration of the scleral entry wound where you can see it being uniplanar with the 25 gauge, which I'll show next, and a biplanar with the 23 gauge trocar. It is also possible to see the wound apposition after the surgery to ensure that there is good closure of the wound. Okay, going on to some of the case examples that we have here for VIP. So for vitreomacular traction, VMT, you can, this particular device helps us to assess the strength of the vitreomacular adhesions. Therefore, it decreases the risk of deroofing of the foveal cyst if there is an inadvertent creation of a macular hole. It also helps in complete removal of the ERM or the ILM and prevents grasping of the retina in our instruments because we are actually able to see how deep we are going. Thereby, we can avoid iatrogenic retinal tears or breaks during surgery. So you can actually see the membrane being lifted off the retina. This is a case with a macular traction with a full thickness macular hole. Here again inadvertent nerve fiber layer touch or breaks can be avoided. We can also do away with staining or using vital dyes, as the peeled ILM is very well visualized as a scroll membrane. I'll show you some more images later. In case of failed macular hole surgeries, the edge of any previously peeled ILM can also be visualized, and you can observe in some cases the opposition of the edges of the macular hole after the ILM has been peeled. So going on to epiretinal membranes, this is another video where we've seen the peeling of the membrane can be seen. There you can see the membrane at the end of surgery. This is a case of macular TRD. It helps in basically initiating delamination or segmentation of membranes with improved precision. It also helps to identify a safe plane to initiate the membrane peeling in case of a diffuse or a plastered tractional retinal detachment. And at the end of surgery, it helps to determine if any residual traction is persisting in the form of secondary or tertiary membranes, and also for the adequacy of membrane peeling. Going on to a case of myopic foveoschisis, here again multiple staining processes can be avoided by confirming intraoperatively that no posterior hyaloid has been left behind. In particularly myopic eyes, there is a longer axial length and poor contrast of the staining. So MIOCT actually can help better assess the internal limiting membrane. Since the myopic retinae are much thinner, iatrogenic breaks may be prevented by better visualization of these planes intraoperatively using this device. Couple of points how it can also help us during retinal detachment surgeries. It can help in induction of PVD, detection of any residual subretinal fluid at the posterior pole, for looking for completion of the fluid air exchange. It can also detect the presence of PVR changes and rolled edges of retinal flakes, like you can see in this particular case. I'll show that image. So this is during regmatogenous retinal detachment, where you can actually see the PFCL being injected. You can see the flattening of the posterior pole. This is during air silicone oil exchange. You can see the meniscus very clearly on the OCT. Yeah, so now it's disappearing. And this is where what I was talking about, where you can see the rolled edge of the break very well. So these are all again intraoperative OCT pictures which will help us assess how much of PVR is there in this particular case. It also is very helpful during pars planar lensectomy, because the anterosegment details are very well delineated on MIOCT, and it's also to monitor to keep for an intact anterior capsule to allow for a placement of an IOL at a later stage. Few other conditions where it's helpful is in vitreous hemorrhage. This is basically preoperatively it won't be possible for us to actually assess the macula. So intraoperatively, once we clear out the vitreous hemorrhage, you'll be able to look for presence of membranes or for macular edema, since you may not be able to do any of these assessments with the vitreous hemorrhage in situ. We've not really used it, but some of the ways in which it can help in ROP is to actually assess the depth of the pre-retinal membranes during lens sparing vitrectomy, or to determine the extent of both the horizontal and anteroposterior tractional elements that there could be. And it is also helpful in ROP and other vascular retinopathies like FEVR to image the flat neovascular fronts, which we have actually been able to do with a couple of other investigative modalities like OCTA. The instrument does have some drawbacks, in the sense targeting the OCT field of view to the area of interest is sometimes difficult. There are no calipers, so we can't as of now still measure the edema. Visualization of the instrument and the underlying retina can sometimes be affected by the optical properties of the surgical instruments that we use. So this can cause obscuration due to backshadowing. So for example, here the instrument shadow is quite high. So metallic instruments like forceps and needles with high reflectivity with total shadowing below the instrument can create a problem. Whereas with polyamide materials, there's only moderate reflectivity, subtotal shadowing. Silicon instrumentation, of course, there's no problem with very minimal shadowing. So there has been a publication in AJO in 2014 where they have done a prospective intraoperative and perioperative ophthalmic imaging with intraoperative OCT. It's called as a Pioneer study. And their 2-year results had 531 eyes with 275 anterior and 256 posterior segment. They found that the information gained from intraoperative OCT may actually impact surgical decision making in a high frequency in both anterior and posterior segment cases. So in conclusion, it does have a promising role as an adjunct in retinal surgeries. It has the potential to transform the OCT from a research tool into a surgical assistive device, because it actually is sometimes the third hand. It achieves a greater understanding of the intraoperative retinal morphology changes that by observing the real-time instrument tissue interaction, which was not possible before. And it can help prognosticate surgical outcomes more objectively. Thank you very much.